This program is a presentation of UCTV for educational and non-commercial use only.
Welcome back, everyone. Again, my name is Descartes Lee, and I'm the chair of this UCSF mini medical school for the public entitled Science of the Mind. And wanted to welcome you all back and thank you for being a really great audience. I've been very pleased with the feedback from the speakers about you, saying what a great audience and group you've been. And so I'm hoping you'll return the favor this evening, and not necessarily saying totally wonderful things with the speaker, but giving us actual honest feedback and suggestions about how we can make this course better for you. Today is the last presentation out of the 6 that we did, and I thought it was a very good kind of broad overview of a lot of different topics in psychiatry. We talked about, just to remind you, we talked about, Dr. Wolkowitz talked about DNA and stress and depression. Dr. Stephen Hall talked about aging and maintaining mood throughout the life cycle. Dr. Allison Harvey talked to you about sleep and its importance in maintaining your mood. I talked about kind of the recent treatments for depression, mostly brain interventions and what they tell us about the brain. And then last week we had a great presentation by Dr. Paul Ekman about the face and facial expression. And today I'm really pleased to present Dr. Stuart Eisendrath, who's going to be talking to us about mindfulness and maintaining mood through mindfulness. And I think it's very appropriate that he's going to be talking about some techniques that have been around for many thousands of years. And it's, I think, a cool way to kind of end up the course kind of at the beginning in some ways. Let me just say a little bit about Dr. Eisendrath before we get started. He is a professor of psychiatry in our department. He is the director of the UCSF Depression Center. He's also director of the clinical services at Langley Porter, meaning he kind of oversees all the clinical service that are provided by us. So in a way, he's my boss, so I have to say good things about him. But I would say good things about him no matter what. He has extensive clinical experience. He's been interested in the mind-body conundrum for a very long time. He teaches evidence-based psychotherapies, including mindfulness-based cognitive therapy, which he's going to talk to you about today, cognitive behavioral therapy, and interpersonal therapy. I have to, on a personal note, he has been a great role model for me. He's been a mentor to me. And I have to say I think it was 5 or maybe 10 years now, Stuart came to me and we were talking about meditation and mindfulness and how he was very interested in this. And I thought to myself, he's already so wise and relaxed and has so much perspective on things. He doesn't need to meditate anymore. It's kind of like if he does this, it's kind of like the rich getting richer. You know, it's other people like me who we need to meditate more. So I'm very pleased to introduce Dr. Eisendrath, and thank you for coming.
Thank you very much for that nice introduction. I'm happy to be here and be closing out the series. It sounds like you've had a great collection of speakers. I'm going to be talking about mindfulness meditation, and sometimes that goes by various names depending on the setting that you're talking about. But we'll be focusing on mindfulness meditation and how you can use it in various ways to help yourself deal with regulating moods. And I'm going to be doing that by discussing a bit about what mindfulness is, and then discussing some of the scientific literature about applying mindfulness meditation to different clinical problems. And then we'll do some mindfulness exercise, a little bit of experience, and have a chance to talk about that a little bit, and then talk about some of the current theories about how mindfulness meditation actually may be helpful. What is it really doing in terms of its beneficial effects? As Descartes said, mindfulness meditation isn't really something new. It's been around for 2,500 years or more. And in fact, if you look at many of the world religions, some type of meditation similar to mindfulness meditation has been a part of it in one way or another. But we're going to talk about it really separate from any particular religious focus and how it can be applied no matter what religion you might be, and how it can be useful. So what is mindfulness? Well, what we mean by mindfulness is a couple of different definitions of it. One, and probably the most commonly quoted one, is the top one by Jon Kabat-Zinn, where mindfulness means paying attention in a particular way, on purpose, in the present moment, and non-judgmentally. So each one of those phrases is important in terms of how you think about mindfulness. And we'll see that in a little bit, I think, as we go through some of this. Another way of thinking about mindfulness is its non-evaluative awareness to one's inner and outer environment. That means seeing things as they are, accepting things as they are, not judging them good or bad, but just accepting them as they are. I'd like to just illustrate, though, that this is not that readily done in our everyday life often. Most of the time, we go through life without much mindfulness. I mean, you know, if you go to, you're driving along and you get to a stoplight and you realize, geez, you may have gone through another stoplight, or there were 3 stoplights. Did you stop for them or not? You know, you may be driving, not really paying much attention to what's been going on. Sort of a mindless way. It may still be, or an automatic mode, if you will, which can be beneficial. It can help you get through a lot of things, and it's good, you know, we do things automatically, like our breathing is automatic and so on. But that when we talk about mindfulness, we're talking about bringing attention to focus on something very specifically. That's the essence of mindfulness. Mindfulness can be thought of as if it's a searchlight that you're bringing to bear and focusing on something. And in our mindfulness exercises, as we teach them in our classes, we may focus on the breath or the body or different sensations, but you can also bring it to bear on virtually anything. And it's not so easy. I want to give you a quick example of this. I'm going to play something for you, and it's a little scene, and I want you to pay close attention to it and see if you notice anything unusual about it. Okay, did anybody notice anything unusual happening there? How many didn't notice anything special? Raise your hand. Okay, so a pretty good number. How many did notice something? Okay, maybe about a quarter of you. What did you notice, sir? The shirt and different people. Okay. What do others notice anything else? His eyes were closed. Okay, how many noticed a different shirt? And how many notice a different person? So really about maybe 10% of you notice that. Let's look at it again. Still looks the same. You want to see it again? It is a different person. It's just what this is from the Visual Cognition Laboratory. Usually about 80% of people do not identify that it's a different person. And so 20% on the first go-round pick it up, 80% don't. And you're just about in that same ballpark. The reason I'm showing that particular thing is really mainly for fun. But it also highlights of paying attention is not that easy to do. Even when I asked you to watch it and observe it, it can be quite challenging.
But there are a lot of things to pay attention.
There are, but they were all right there. But there are a lot of things to focus on. You're right. And what you're going to focus on is something you have to turn that searchlight towards. And that can be a challenge sometimes. So there's a lot of things that you could notice that were different from one to the other. His affect, his shirt, his glasses, his eyes, and the person, there were a lot of things going on there that might be noticed that were quite different. And that's one of the things about mindfulness. You can actually bring your attention to different elements at different points in time. And the nice thing about mindfulness is that you actually are free to choose what you're going to focus on. So mindfulness is something, we'll talk more about how it's used and do some of exercise with it as well as we go along here. But that was just an example of trying to focus the attention and how challenging it can be. And the idea of learning mindfulness in our classes and the various classes that I'll mention is that it takes a while to train your attention to be able to focus on something. So what has mindfulness been used for? It's been used for a variety of things. Actually, Jon Kabat-Zinn sort of brought it to this country in a modern version with stress reduction, mindfulness-based stress reduction, about 30 years ago. And that, in turn, has been applied to a variety of conditions such as chronic pain, psoriasis, eating disorders, fibromyalgia, cancer. Lately, it's been used for parenting and childbirth discomfort. And on the psychiatric side of things, it's been used for treating anxiety, depression, borderline personality disorder, addictions in mindfulness-based relapse prevention, and to some extent for bipolar disorder. So it's been used for sort of an increasing number of different conditions. And this is really not an exhaustive list. It's just to give you a taste of what it has been used for in recent years. And in most of these things, there are studies that demonstrate its effectiveness for these conditions. And I'm going to give you some of those studies now. This is a study that was done for generalized anxiety disorder, where a person doesn't have a particular phobia or panic disorder, but just generally feels anxious most of the day. And this is, I don't want to go into all the details of it, but this is the Beck Anxiety Inventory. And as you can see, at baseline, the score was 19, and by the end of the training, which was 8 weeks, it had been cut in half to 8.91. And similar, well, some of these other things are similar. This is the profile of moods, showed a similar nice change where a decrease in score is good. So it was very useful for these people, and this has been shown in several other studies as well. You have a question? This particular study did not have a control group. This was an open trial. And we'll talk about control groups a little bit later as we go along. This is a mindfulness scale, the mindfulness awareness scale that increased as you would expect it to with the training. So it went from 3.68 up to 4.2. So that is one particular scale that is used to measure mindfulness. So the people became more mindful by the end of the training. So as the mindfulness went up, the anxiety levels went down. In another study that did have a control group, a small study of people with bipolar disorder, looking at people between episodes, not people in full-blown episodes of bipolar disorder, looking at anxiety and depression levels. This is Beck Anxiety and Beck Depression Inventory. In the control group, you can see that the pre-level of anxiety was 11 and actually worsened, went up to 20, whereas in the group receiving mindfulness-based cognitive therapy, a special form of mindfulness I'm going to tell you more about, it went down from 12 to 6, and the depression levels, again, went up a bit in the control group and went down to about 1/2 in the people getting mindfulness-based cognitive therapy. That was a weightless control. But the typical control group would be to have the other half of the group wait and not get the intervention and get the usual treatment. So what is mindfulness-based cognitive therapy? Well, there's basically sort of one main form of mindfulness that many people learn, and it's called mindfulness-based stress reduction. And that's, as I mentioned earlier, is something that was developed by John Kabat-Zinn. And that has been used to treat a lot of physical ailments, things like chronic pain, or dealing with a cardiac condition or stress reduction and so on. But in terms of dealing with emotions, a derivative of that, sort of modeled after mindfulness-based stress reduction, is mindfulness-based cognitive therapy. So it looks quite similar to mindfulness-based stress reduction. If you were looking at it from up above, you'd see it's the same. It's eight weeks long, once a week, group format, and the sessions are actually 2¼ hours long. And then afterwards, people come to a monthly maintenance session, typically, and they also practice while they're going to the once a week for 8 weeks. They have homework and practice at home the other 6 days of the week, doing meditations on their own, listening to CDs or doing other forms of meditation. And the group sizes vary from 6 to 14 typically, and they do things like formal meditations called a body scan, and we're going to do a bit of one a little later. Mindful stretching, things like yoga or mindfulness of the breath, or listening to sounds mindfully. And then we teach informal techniques like how to be mindful in your everyday life. So like when you're eating a meal, like eating it mindfully, or when you're brushing your teeth, what does it actually feel like if you pay attention to it? I mean, these are things that we normally do. Think about eating. Normally when you eat, do you taste your food? I mean, typically we're talking with somebody else, we're reading the paper, we're watching TV, we're doing anything but really tasting the food. It can be remarkable to sit in silence and just taste the food and paying attention to what the texture of the food is, the smells, the tastes. Just to do it for 5 minutes can be really remarkable. I'll give you a bit of homework. I'll tell you something that you can try doing just as an illustration of that. One of the exercises from mindfulness-based stress reduction or mindfulness-based cognitive therapy is eating a raisin mindfully. And I know some people don't like raisins, some do, but whatever you do, try eating a raisin mindfully. So when you get a chance, pick up some raisins, take one in your hand, and look at it as if you've never seen it before, like you're just fresh, with fresh eyes. Notice it, what it's like. Bring it slowly to your mouth, smelling it, and then put it in your mouth. Close your eyes and taste it. Move it around in your mouth, and then slowly begin to chew it. And you may taste it for the first time. I know I did this in my 50s, and normally we eat raisins, 1, 2, if you eat them at all. I mean, you're throwing them in, really not tasting them. And here's the little secret homework for you. When you do start to chew the raisin, you will taste it in a specific portion of your mouth. Your job is to find out where. We also do things like a 3-minute breathing space, and to teach people a very short, portable meditation that they can take with them wherever they go. But the heart of mindfulness-based cognitive therapy, or MBCT, is to help teach people to see that their thoughts that they develop are just mental events and not facts. A lot of times when we have thoughts, first of all, when the thoughts occur, we make a critical error when we have thoughts. We believe them. And thoughts are just mental events. They're transient. And for people who are prone towards anxiety or depression, those thoughts tend to run in negative directions. So thoughts are kind of things that pop up. Sylvia Boorstein talks about this as our thoughts are like popcorn poppers, where, thoughts just pop up. And, you're maybe sitting very quietly, focusing on your breath or some other focus, and you can notice a thought just emerge. And it may be, something negative. But if you're prone towards depression or something negative, in terms of an anxious thought. And those thoughts, if you start to believe those thoughts, can get you into a lot of trouble. Like, oh, I notice I wonder how I'm doing giving this talk today. Maybe, it's not going over so well, and this is happening, and this fellow doesn't look too wide awake, and here we're going on, right away a cascade of things go on, and pretty soon I'm saying, well, I think I'll say goodnight, and that would be moving towards catastrophic thinking, catastrophizing, that is very common in anxiety disorders or depression. And so those kinds of thoughts, what we learn in MBCT is that those thoughts are just thoughts. They're not real. They're not facts. And once people learn this, it really frees them up quite a bit to be able to respond to them more skillfully. So if I have that thought, I can decide, well, am I going to pay attention to it or not? I have a choice. I don't have to pay attention to it. So how do we get people to recognize that it's just a mental event? Right. We do that in various ways. Let's take an example right here. Let's take an example like this. Imagine that you're walking down the street, and you see somebody on the other side of the street, and you wave to that person, and the other person keeps walking by, and they don't wave back. What do you think? What do you feel? Or just raise your hand if you have a thought or reaction.
They don't like me.
They don't like me, okay. What was that?
They didn't see you.
They didn't see me, okay.
Wrong person.
I didn't see them right, okay.
They're talking on the telephone.
They're on the phone. They're not paying attention, okay.
Just didn't recognize me.
They didn't recognize me, okay. Maybe they're rude. Okay. Anybody else?
Rejection.
They're rejecting me. Okay, good. Any other? How do you feel in this situation? Confused, I heard. What else? Hurt. Rejected. Embarrassed. Sad. Angry. Relieved. Okay. So what we do in the class is we have 16 people. We go around and say, okay, what's going on? Now, what is the fact of that particular situation? No, that's right. Nobody actually knows. I may be having all of these thoughts, and I may be reacting. In one of our classes where we did this, somebody said, that's exactly what happened with this guy, and I haven't talked to him since. That's what happened. And he was certain that he had been rejected by this person he had seen, and that was it. And versus, I'll tell you, by the end of the 8 weeks, the guy says, I may have made a mistake. So that's what mindfulness gives you, some space. Some people think of it as mindfulness gives you space between the spark and the flame. So there's a little bit of a gap there. So instead of having to react, say, angrily, like I've just been rejected and I'm never going to talk to that person again. In fact, I'm going to send them an angry email or, who knows. You could say, well, maybe there's another possibility. I feel rejected, but, maybe they were on the cell phone. Maybe they're depressed and they're not paying attention. Or maybe they just got chewed out by their boss and they're upset. Or all kinds of different possibilities. So there is no particular fact. So it's helping people realize that there is no fact. Even though we may believe it, and the initial response is to believe it absolutely, the reality is there may not be any fact there to hang your hat on. It's just a thought. I had the thought. And instead of believing it and running with it, we say, well, it's just a thought. It may or may not be correct. And in mindfulness, you have a choice of whether you let that thought go or not, which we'll talk about. We call this decentering in mindfulness, where you get some distance from the thought, from a thought. Sometimes it's called metacognition, or cognition is, what we psychiatrists use for a thought, fancy word, and metacognition because it's beyond the thought. It's like looking at the thought process. Like, we just got 20 different possibilities for what happened in that transaction. And those are different thoughts about it. There is no fact that we can hang our hat on. So rather than saying, well, this is the way it is, I can choose one that works better for me than the one I just chose. Let me give you an illustration about this, and let me contrast mindfulness-based cognitive therapy with cognitive behavior therapy, which is more traditional. In cognitive behavior therapy, let's use an example of somebody who's depressed. In cognitive behavior therapy, the typical kind of picture might be like this. A person who's depressed would say something like, I'm not a good person, or I'm a guilty person, I'm an unworthy person, I'm a failure, I haven't done much, I'll never be a success. Those are typical depressive thoughts. I mean, we have some scales I have a list of the top 30 depressive thoughts. They're very well worked out. And the issue is now, in cognitive therapy, you might say, when the person says, I'm an unworthy person, or I'm not a good person, in cognitive behavior therapy, we'd say, okay, that's a negative thought. Let's try to weigh the evidence and answer back to that thought. So when you say I'm not a good person, what's the evidence that supports that idea or refutes that idea? What's the evidence that you're not a good person? What's the evidence that you are a good person? And then say, well, I was successful at this, I failed at that, so maybe I'm not a complete failure, maybe I'm okay as a person, but I'm not a very good person, but I'm not terrible either. So maybe a more balanced thought would be, I'm okay as a person, but not really a good person. So you help the person come up with a change in the thought content. Now, the trouble with this in, say, depression is the person usually has many years of evidence. And when you ask them for evidence, they may say, well, you want evidence? I have a bushel basket full. Because they've been viewing things very negatively for a long time. So mindfulness-based cognitive therapy has a different approach. First of all, when they say, I'm not a good person, or I'm a rotten person, or something like that, what we say is, wait, actually, you're having the thought you're a rotten person. As soon as you do that, you're helping the person start to decenter, because they're moving away from identifying with that thought. So I'm having the thought, and now I don't have to argue about it. I don't have to have evidence for or against it. I can decide whether I'm going to hang on to that thought or let it go, just like you just did now. Like, I had the thought when the person didn't wave back to me that they don't like me. Well, I can hang on to that thought, or I say, well, actually, I don't know. Maybe they just were on the cell phone and they didn't hear me or didn't see me. So I don't really know. Well, I'm having the thought I'm not a worthy person, but, I don't have to hang on to it and start running with that idea. I can let it go. So they start to learn how to distance themselves from those thoughts and be able to be, without having to get into an argument about whether it's true or not. So it's thought process focuses. It helps the person change the relationship to their thoughts rather than trying to change the thought content itself. This is a radically different way of being in the world, because most of us have the thought, a thought, and we believe it. We actually go around, we don't even question it. We have the thought, whatever the case may be. If you're prone towards depression, I'm not a good person, or I'm this or that, or if you're prone towards anxiety, like things are going to turn out terrible, that's exactly what you believe without ever stepping back and realizing it's just a thought. I mean, depression, the way we understand it, is really the person feels as if they have experienced a loss. Anxiety is they're anticipating a loss occurring. So this relates to something we mentioned earlier about mindfulness. We're trying to bring attention to the present moment and getting away from focused on the past or the future and just focus on the present moment. It's something that we don't do typically. Sometimes we do it in certain experiences, and some of us are more mindful and are naturally than others. And when we look at people in terms of mindfulness scales, if we did it right here in this room, there'd be, a variability amongst that, amongst the group here. Some people who perhaps have never had any mindfulness may be very mindful just naturally, and others less so. But it is a different way of looking at things. It's bringing attention to things that we don't typically do. That's why remember in that initial definition, it's bringing attention with intention. So it's something like, wow, I'm actually looking at my thought. I just had this thought, about this, and I'm looking at it. So it doesn't require that you be depressed or that you be anxious. You don't have to do that at all. I mean, certainly mindfulness meditation does not require that you have that. But I'm using these as some examples of how it can help with different mood states. In terms of, to give you maybe another way of looking at this, mindfulness-based cognitive therapy, when it was originally developed, was first called selective attention training. So it means you have to have the ability to focus the attention. onto whatever you're focusing on, the breath, the body, or so on. There's a relationship. They are quite different, you're right. And I'm not sure that whether mindfulness-based cognitive therapy is exactly the best term, but it's the one that has been utilized the most. They use cognitive therapy techniques, but they use them in a different way. Like you could use this exercise with the person, the hand waving, in a cognitive therapy way. We use it to show attention to thought processes. In cognitive therapy, you might help the person try to change the thought content. There is some room for confusion, and you have to you have to understand. I don't want to go into all the. There's a lot of differences. Some of the exercises that are used in the course have similarity. A lot of the things, in fact, have similarity to traditional cognitive therapy things. For example, like when we use the automatic thought questionnaire of that top 30 list of depressive thoughts, that was originally developed for cognitive therapy. And in cognitive therapy, what you would do with a person is say, look, pick out what are your top 10, your Letterman top 5 thoughts. And then let's challenge those and try to change them like this. But we use that same list, but we don't try to change them. What we do is try to notice those thoughts are quite variable. Here's just an example of major depression and how mindfulness can be useful. If you look at major depression, that's another term for clinical depression. If you look at, say, a young person in childhood and adolescent, you have a life stressor that may be significant. It may lead to symptoms. This is the threshold for exhibiting for a diagnosis, this line here. And so a person may have symptoms, but they don't meet the criteria, and then here they break through. But if you notice, actually, as the person gets older, the amount of stress that they need to have precipitate an episode is actually less. So that with time, the brain gets sensitized and may activate episodes of depression with less stress. So you have to develop some strategy for preventing these episodes. And the way we currently do it is either with antidepressants on a maintenance basis, or the newest thing is mindfulness-based cognitive therapy. So in mindfulness-based cognitive therapy, this is a study by Teasdale. They took people who had recovered from depression completely and gave half of the people mindfulness-based cognitive therapy and half didn't get it, and followed them for a year. The control was treatment as usual. And in the people who followed for a year, they had basically twice the chance of staying free of depression if they had received mindfulness-based cognitive therapy. This study was replicated by Teasdale and his colleague Helen Ma, and they actually had even better results in this replication study. So they had over twice the chance of staying free. But this has some weakness in it because this is just treatment as usual. This group is getting 8 weeks of the good stuff, and the other group is not getting that. So Koiken at Exeter University in England actually did a very interesting study, which is a better controlled study, where he took people who had recovered with antidepressants from depression, and they were on antidepressants, and randomized them to receive either mindfulness-based cognitive therapy and taper off their medication, or continue with antidepressants. That was the control. And that's the conventional treatment. This was a high-risk group, though. These are people who had multiple episodes of depression. So they were likely, and they picked that because they wanted to see that they were going to have, they were, in a sense, hoping they would have be able to see the relapses in a year's period. And what they found was that in the comparison between mindfulness-based cognitive therapy and antidepressants, they were equivalent. Statistically, one was as good as the other. Actually, mindfulness-based cognitive therapy had a better rate of preventing relapse, 47% relapse versus 60% with antidepressants, but statistically in the analysis they were equivalent. But when they looked at depression levels and actual quality of life, the mindfulness group was actually better. So this was a very interesting study that actually is a very good control. This was done in England, and the control was treatment by their general practitioner. Now, I just want to mention something that is, I'm particularly interested, as Descartes mentioned, I'm director of the Depression Center here, and I am interested in depression, so I'll impose that on you a little bit. But we have a problem here with treatment-resistant depression in this country and actually in the world. Here's an interesting fact. You know that major depression, clinical depression, is the #1 cause of disability in the world after infectious diseases. That's in the developing countries. In, say, example, North America, in the developed countries, it's #1. More so than cancer or coronary artery disease. Some of it has to do with stigma and not addressing problems, but that's changing. Part of it is we've developed the Depression Center here, and there's a bill before Congress now that was introduced by Senator Stabenow from Michigan with a co-sponsorship by 3 other senators to establish comprehensive depression centers across the country, similar to comprehensive cancer centers that were established 30 years ago. If you'll remember, the cancer used to be the C word. If somebody had cancer, well, let's not talk about it. And depression is much the same. And what we want to do by having depression centers is move it out so it is talked about. Because, depression is a very common entity. It's the most common thing that anybody in this room is going to deal with amongst ourselves or loved ones or friends that we have. And it's something we need to be better at treating. As this illustrates, here's something the drug companies might not like either. If you take the STAR-D trial, which was a sequenced treatment alternatives to relieve depression, this was the largest NIMH trial ever done, $54 million. What it did was treat people and said, so we don't really know how to treat people sequentially. If we treat them and they don't respond, what do we do? So it started out with people, gave each person citalopram. They gave it because that was off patent. That's why they selected that drug. They gave everybody citalopram, which is otherwise known as Celexa. If they didn't respond to that, a full dose of that after 12 weeks, then they went on to a second stage and received a different antidepressant or a combination or cognitive therapy. If they didn't respond to that, they went on to a third stage or to a fourth stage. Now, if you look at this, this is really remarkable. After one full treatment, only 30% of the people had fully recovered. That means 70% had not recovered. If they then went on to the second stage, they added another 20%. So after 2 full treatments, that means 50% had fully recovered, but 50% hadn't. So that means we have a big problem on our hand. And then if you actually follow it out for all 4 stages of treatment, by the end of it, only 43% of the people are still in full recovery after 1 year of treatment. So it's a very challenging disorder. That's why we need other treatments besides just throwing another round of medication. We need to have other things and I'm not against medication by any means. They can be life-saving. But we have to add things to it, and mindfulness-based cognitive therapy, mindfulness techniques may be a very valuable addition. I'll show you briefly what we did. We took people And I don't have to go into the details. They had the Beck score of about 24. We compared them to another group who received medication management. And this shows the results, that the people who received MBCT, and in our depression center, the way we follow, there's an artifact here. Actually, the medication management patients were at 12 weeks was their endpoint, because that's how long we periodically follow them. And in MBCT, we capture them at the end of 8 weeks. And there was a decrease in anxiety and a very marked decrease in depression levels to about half in this population. So it was very effective in this group. This just represents it. So quite a few higher, you can see 30% of the people completely recovered versus only 10% in the medication management only. And these are some other studies that showed these are open trials without controls, but showed similar reductions in depression levels. It probably isn't important, except to say there's now growing evidence. It isn't important to go into the details of these, but there's growing evidence that mindfulness-based cognitive therapy, which was originally developed just to prevent relapse, can actually be used as a treatment modality for depression as well. This was a study by Kingston, which was a randomized study comparing mindfulness-based cognitive therapy to treatment as usual, showing a marked effect for mindfulness. So, how does mindfulness work? What we do in our classes are really a series of different meditations, ranging from body scans to sitting meditations to sound meditations. And what we find is some people love the body scan, some people hate the body scan, and they like sitting meditation, or vice versa. And really what we try to do is say, here's a menu of things, and some people like walking meditations, for example. We're going to give you a range of things, and you get to pick for yourself. And the idea of this is you decide for yourself what really works for you. And if the body scan is not something that is what you connect to, that's okay. It's just some people are more oriented one way versus another. So you may sometimes you may pay attention to, well, what's going on there that I don't notice this? I mean, there's a lot that could be done with that particular thought. I mean, without going into it more specifically, sometimes you get to notice things as you're doing a body scan, like, geez, I'm holding a lot of tension in my shoulders, like, at the end of each day. Or I'm really angry at my boss today, and, I have a headache, a lot of tension here. Or something is going on that you may notice certain things that get brought to your attempt. That's where some of the insight comes from, actually, is that when you sit down and give yourself the opportunity to look at these things, you can learn a tremendous amount from these sort of seemingly small things. There's variation. You can do a body scan starting with your head, and some teachers do it that way. Some people do it with the feet. I would not say one side versus the other to stimulate one side of the brain versus the other. Well, that's an interesting thing that could be potentially tested. People do it various ways. Sometimes people start with the feet because they think it's furthest away from the head, and what we're trying to do is get people into the present moment and not be thinking. And starting with the feet is sort of a vehicle for doing that. Some people start with the head. There's no particular convention or reason that you could specifically say scientifically you should do one thing versus the other. But it's very common that people, as you probably all experienced, for your minds to wander. It's what minds do. Most people have the misconception about meditation is I'm doing it wrong because my mind wandered. But meditation is really your mind wanders and you notice it and then you bring it back. Your mind wanders, you bring it back. And if it wanders 1,000 times, you bring it back. And that's the meditation. It isn't just, I lock my mind in on my toes and that's it. It's becoming gentler and kinder with yourself about your mind wandering. So let's talk about this a little bit. Focus on the here and now. The breath coming in and out, and what's going on in your left leg and foot, right? And dropping away everything else. And this relates to moods. How? Well, as we talked about, with a lot of anxiety and depression type of moods, people they're looking towards the future disasters that are going to happen or the ones that have already happened. They feel as if they've happened. So if you help them to say, focus, let's not worry about that. Let's focus on the present moment. It is naturally helps the mood. At least this is what these are theories. I have to say, nobody is completely clear on exactly how. These are some of our theories about why this may be. We know that it can be quite helpful. Why it is, we're still working on. And that selective attention by itself, focusing on, say, the foot or the breath, may relate to this, that you have a tendency, if you're focused on something like that you're not doing things like ruminating. Ruminating is something that tends to lead to either anxiety or depression. Ruminating most people, here's another type of thought that most people think, I'm ruminating about something. They maybe don't even identify it as ruminating. They just say, well, listen, I had this interaction with this person at work today. I should have said this to them. I wish I had said that. If I'd said this, this would have happened. And, well, if I'd said that, that wouldn't have been so good. So maybe I should have said this. And they think what are they doing? They never step back and decenter. What am I actually doing when I'm ruminating? If you ask them, well, they think, well, I'm getting ready in case it happens again. But it doesn't lead to problem resolution. In fact, rumination has a tendency to lead to worse mood. So if you're focused on your breath, it sort of fills up your mind's capacity. You're not ruminating. So focusing your attention decreases this. We also think that mindfulness can enhance compassion and self-compassion. So it's towards yourself and towards others. The decentering is an important element of mindfulness because you start to be able to notice thoughts as they emerge. It takes usually having practice at this and having a steady focus for a while, and then you can start to notice when these thoughts emerge, and you can start seeing them as, well, actually, this is just a thought, and not be so trapped by it. And that may be an important element of CBT, in fact, because what we notice in traditional cognitive behavior therapy, when we've looked at that, people actually start to improve before they change the thought content. We said, well, in CBT, you have to help people change the thought content. Actually, that is a slight misconception. People start to improve in CBT as soon as they start to notice that they're having a thought. As soon as the person can say, instead of I'm an unworthy person, that I'm having the thought I'm an unworthy person, that alone helps them improve. Here's an important idea about mindfulness, is that mindfulness may help you accept things as they are. Or in other words, this equation is quite useful, that the amount of suffering a person goes through, and we all suffer to some extent, is equal to resistance times the pain. And this can be emotional pain or physical pain. If you resist it, you actually end up suffering more. So if you say, what do I mean by that? This is not to say that resistance acceptance means, so if you lower resistance, you're just accepting it and resigning yourself. Resistance actually means, lowering resistance means like what we see in depression or pain, for example, is that a person has pain, let's say a physical pain, where they may say, oh, it's terrible, I have this pain. It's, I'm a weak person because I have this pain. I shouldn't have this pain. It's unfair I have this pain. I'll never get over this pain. All of this is the resistance versus saying, you know, I have these physical sensations which are painful, and I can accept them as they are right now, and not have and go on living my life with them. And if you actually lower the resistance, you lower the amount of what Sapolsky has called adventitious suffering that only humans do. By that I mean, if you have, you know, if an animal steps on a thorn in the woods, the animal feels pain sensations. But they don't say, you know, did I deserve this? Or, maybe I should have listened to what my mother said, or, I should have done this. They don't go into all kinds of things around it. They still have pain. The pain is still there, but the amount of stuff that gets laid on top of it and multiplies it is diminished. And that's the same whether you're talking about physical pain or emotional pain. So it may be, even with depression, it can be quite the same. For example, Winston Churchill described his depression as being the black dog. You'd say the black dog is back today. And in fact, in Australia, they have a black dog depression clinic, which is doing quite a bit of research on depression. It's some very interesting work. But I like that image because, you could say, well, okay, the black dog is back today, and now how am I going to react to this? I could be terrified. I can, want to escape and so on. But if I say, well, okay, I'm going to accept it just as it is, I can actually look at it, study it, observe what's going on, and then the black dog it may still not be a beautiful dog, but I don't have to be terrified, and that resistance, the terror component can be greatly decreased. And that's true in depression. For example, many people we find are very depressed about being depressed. That is, they're laying on additional suffering to an already painful emotional state. And it doesn't mean I'm suggesting that they accept it and resign themselves to it, but if they can accept it and say, okay, this is what it is today, that then they're in a position actually to do something about it without the terror and so on. And as many of you know, for example, in substance abuse, acceptance and lowering the resistance in a sense. Acceptance is sort of the reciprocal of the resistance. If a person with substance abuse can never do anything about their condition until they accept that they have the problem. If they don't accept they have a problem, they will not be in a position to do anything about it. Here's a little cartoon. I also mentioned that we think that self-compassion may be playing a role. How does self-compassion work? Well, it may help buffer some of the feelings of criticism that one has towards the self. People with depression or anxiety are often very critical of themselves, and that you learn with mindfulness to be kinder and gentler to yourself. If you can accept yourself, say, okay, my mind wandered. I can accept that without saying, oh boy, I'm stupid, or boy, I'm a failure at this, or I'm not doing it as good as the person next to me. Say, oh, my mind wandered. I just note it and bring the attention back, and I can accept that. then as one person said in the group, if I can forgive myself for my mind wandering, I guess I can forgive myself for other things. So people start to say things like this: I'm gentler on myself, I'm less critical, I can talk back to myself more, and handle stress better. We did another study. I won't say more about it, except it highlighted. This was it showed that when we measured certain factors in these people, the anxiety levels decreased. And just in terms of what is different about this slide compared to some of the other things, we actually measured rumination, and that people actually did ruminate less using mindfulness techniques. Okay, here's just a couple slides, and then we'll open up for questions. Now, there is evidence about biological changes with mindfulness. At the University of Wisconsin, Richie Davidson and his colleagues did an interesting study a few years ago. They taught people mindfulness-based stress reduction and showed that after 8 weeks of study, what they did was take a group of employees at a corporation outside of Madison, and half of them got mindfulness-based stress reduction, half of them were waitlisted. And the people who received mindfulness-based stress reduction after 8 weeks had changes in their EEG, their electroencephalogram, where they had activation of their left prefrontal cortex, which is the area of the brain associated with positive mood states. So there's a convergence of evidence about these things that activating certain areas of the brain seem to have powerful mood effects. And you can do it in various ways, directly, say, with transcranial magnetic stimulation, but mindfulness meditation may do similarly. And they also measured antibody levels in response to immunization and found that the people who had received mindfulness training had enhanced antibody response. Now here's, I think, my last slide, almost last. Just to show it, this is an fMRI scan of people who received mindfulness training, 8 weeks of mindfulness training, and what it shows is that people had activation of this portion of the brain. As you see, this is sort of midline. This is a slice. Here's the eyes right here, right? This is a slice. In these people, before the training, they had this central focus, and here you see it's shifted towards the periphery. I don't want to go into all the details because it's a little complicated, but what it's showing is that with 8 weeks of mindfulness training, that these people had a shift in their brain functioning that was measurable using functional MRI techniques. There's two ways of measuring, well, there's two essential ways that we image the brain, is either functional MRI or PET scans. And these are fMRI scans that show these people having a difference by having the mindfulness training compared to being when they started out. And so I think the important element here is that you can make real significant difference in brain functioning through this kind of training, and we're just at the verge of understanding exactly how to do it. In fact, this is our study that we're doing now here. We're taking people who have treatment-resistant depression, and we're randomizing them to receive either mindfulness-based cognitive therapy or the health enhancement program as the control condition. And this health enhancement program consists of physical functioning, music therapy, and nutrition. So it's quite an active control, and we're going to follow them before and after, and then for 1 year afterwards. And we're hoping to add the functional imaging component. This is already underway and funded, and we're hoping to add this functional imaging so that a portion of these people will be able to get this as well. But one of the exciting things about this area is we're learning that by focusing attention, you can actually train the mind to have very powerful effects. 2 weeks ago, we had our depression symposium here, and I think Descartes probably also talked about deep brain stimulation for refractory depression, where Helen Mayberg from Emory spoke, and she's found that by putting an electrode into a certain area of the brain called Area 25 and stimulating it, for people who have severe depression that fails to respond to anything else, she can instantly turn off depression. And then they implant a pacemaker-like device, and the people can have continuous relief of depression. This is not for everybody, because most people don't like to have their head drilled open. But it highlights what the amazing thing about it, I think, is not just that it can work for these people, but she's found a key depression circuit in the brain. Then our next speaker on this, actually from Stanford, Ian Gottlieb, spoke about how they're using fMRI feedback to train people to do the same thing without sticking an electrode in, but by training them in the fMRI machine to actually learn how to do this through feedback, just like biofeedback, only they learn how to control this one area of their brain. So it's pretty powerful, and we think that mindfulness has a somewhat similar effect, and we're going to look to measure this in this study. So let me stop at this point. I'll mention these are some of the collaborators who've worked with me on our study. It's called the Practicing Alternatives to Heal Depression study, and it's looking at people who have failed to respond to 2 or more antidepressant trials, and we'll be doing it over the next several years. Back there?
I just had 2 comments. Number one, I guess it's called meditation practice for a reason. I'm wondering also, has there been any, do you ever work with disaggregating the self so that people can see that they are not necessarily their thoughts? And I think that's, in this culture, you know, one of the foundations of Western thought, every time you say Descartes, I think Rene Descartes, I think, therefore I am. And that's an aspect of Western thought that conflicts with mindfulness training in the sense that what a lot of Eastern traditions see as compulsive ideation or rumination, we see as the essence of the ego or the self being this I think, therefore I am. So it seems like we have a particular disadvantage in mindfulness training if we don't press against some of the foundations of Western thinking.
Yes, I think you're right. That there are different cultures come to this more or less easily, and the view of the self can be an important component of that. So you raised some excellent points. I think they're difficult to get into further here, but I think they're very good points. Yeah?
Dr. Hall mentioned that you can be depressed but not necessarily sad. So, and I've had people tell me that people can be depressed and not know it. So are there other ways depression manifests itself besides just having a bad mood?
Well,
Not in other ways. Because I was very surprised when he said, you're not necessarily sad. That's sort of what, isn't that what most people think? You're sad, you're low, you're down.
That's a common feature of depression, but it's not mandatory to make the diagnosis. And there are people who experience, say, not sadness so much, but lack of ability to enjoy everyday things. So like they normally would enjoy.
Energy.
Well, they lack energy. They lack, I'm sure he showed you, like the 9 cardinal symptoms. And if you have 5 of the 9, that's enough to make the diagnosis. And many people don't have certainly all 9, and depressed mood may not be part of it. And sometimes, particularly as people age, depressed mood may not be the most prominent feature. People may have more physical symptoms, and they may go see their primary care physician more than they go see a psychiatrist, and they go with, I just have lack of energy, I can't enjoy things, and I have this bad back and stomach ache or whatever, headaches or whatever those somatic complaints are. But if you go through the list of symptoms, they may fit the criteria, but they don't have depressed mood. I've treated people. I saw a man some time ago who he had absolutely no depressed mood. He had lost 65 pounds of weight. 65 pounds of weight. But if you ask him, are you depressed? No. Absolutely not. We treated him with an antidepressant, and he responded beautifully, started to function much better, according to his wife, gained weight, and asked him again, well, did you think you were depressed? No, I was never depressed. And so, but his functioning and his ability to enjoy things changed dramatically. So it can be a tricky diagnosis. Yeah.
I work at the UCSF mental health clinic, and I watch pretty much the standard of care around depression is antidepressants, maybe plus talk therapy, usually 20 sessions or less. Maybe a group is recommended. When is this going to become the standard of care? When are we going to actually... there's no way. I know that this is a rhetorical question, but this is wonderful. It's really, I see this as the hope for depression, because I've watched people not respond to antidepressants, or I've watched antidepressants work for a short period of time. And I want more research. How much research do we need before we start prescribing MBSR?
Well, it's a good question, but there are a number of studies, but there's this study is actually the first study that is a randomized controlled trial of actively treating depression. The other studies that I showed you that were randomized trials were for relapse prevention. So this is the first study that actually treats depression. And we're at the stage of building the evidence base for introducing this. If this is effective, it'll be, I think, pretty powerful in moving the field along. The question is, what's the difference or similarity between dialectical behavior therapy? There's a lot of overlap between them. Dialectical behavior therapy has a significant mindfulness component in it. And if you remember from the first slide I mentioned, or one of the early slides about borderline personality disorder, that's designed specifically by Marsha Linehan for dialectical behavior therapy. It usually differs in, it doesn't have specific discrete meditations like this. It has sort of more focal applications of mindfulness, but there's a lot of overlap. There's a lot of things that are developing around this. Dialectical behavior therapy, acceptance and commitment therapy, mindfulness-based cognitive therapy. These are all, they have a lot of overlap between them, and there's different variations, but a lot of connection.
Can you say the name again of the woman who did the deep brain stimulation for area?
Helen Mayberg did the deep brain stimulation for Area 25 for for treatment refractory depression. Back there.
I wanted to see if you could share the difference between NDSR and mindfulness-based cognitive therapy. When I noticed the structure of MBCT, it looked identical to NDSR. And so I'm just curious about this.
Okay, so you're asking what's the difference between MBCT and MBSR? They're quite similar. A lot of the meditations and the basic structure are exactly the same. I'd say that where they differ is MBCT is really focused on depression and anxiety. And it's focused on the emotional side of things. MBSR, if you have taken a class like that, there are people with anxiety and depression, but there's people with heart disease, cancer, pain, fibromyalgia, everything. So it really can't be focused on the emotional aspects per se. So there's much less of a focus, and so there's quite a difference in the feel of the two of them. For somebody who has a more general thing, MBSR is a very good choice. For somebody who's dealing with emotional aspects, MBCT is a more focused effort. But a lot of the meditations are the same, and you could approach it, if you don't have access to MBCT for some reason, you could certainly give MBSR a first shot.
So MBCT is the research that you presented was more for prevention of relapse. And so it sounds like it's not being done for people who are currently depressed. Is that correct? Let's say somebody who qualifies for being in the hospital.
Well, for somebody who qualifies, the question is what is MBCT being used for? MBCT was originally developed for relapse prevention, but there are now, I think, 6 or 7 trials, one randomized small trial showing it to be effective for depression, for active depression. So there are numerous open trials. This will be the first large-scale clinical trial of it. But we are using it here at UCSF for treating people, and the results, have been quite good in our experience with it. But until we finish this study, we can't say for sure. Yeah.
Actually, there are some studies or looking at the effects it has on adolescents or children. Where are those studies being conducted?
Stanford. Well, there's some at Stanford. There's actually one at Pittsburgh also.
And do you know if within those studies they're also looking at the impact this could have on children with spectrum disorders such as autism or Asperger's? Because there is sometimes comorbidity with children that have, let's say, a neurological disorder that's impacting how they interpret information. They oftentimes have comorbidity, depression, and/or anxiety.
I don't know the answer to that. I'm not aware of it, but they could be. And you'd think there might be some utility in terms of training attention and so on, but I just don't know that area well enough.
Wasn't it true that when certain people, when they didn't have a psychological disorder and they did mindfulness, that actually their mood had gone down in one of your studies, or did I misinterpret that? Like early on in one of your sheets?
I don't think so. Yeah. No, I don't think that's true.
Can you talk about the profile of the mood state score was decreased, but that's super negative?
Yes, that was for negative moods. So you have to be careful in interpreting some of those instruments where going down or going up may mean different things. But in that study of generalized anxiety, the anxiety levels went down and the mood improved, and the vigor. Profile moods has different components, and the moods improved with mindfulness. So thank you.